Wow, thank you very much. I really appreciated that. Hopefully you guys can hear me pretty well here. Um, I guess the best way to think about this is I'm an infectious disease specialist who has spent a tremendous amount of time doing research in skilled nursing facilities. Really sort of took it from an academic approach originally. I've now sort of moved into practical methods of infection prevention. Sort of building off of what Tony was saying earlier, my group Expert Stewardship has been doing infection prevention specifically for COVID in skilled nursing facilities in Orange County, long-term acute care facilities, and residential care facilities. We've worked with a number of the ombudsmen to give them proper training in terms of how they can actually enter into COVID facilities and what they can do. I am my background here is actually in the hospital, so you'll have to apologize if you hear a code or something overhead. We are in the middle of a COVID surge and we're getting quite busy. Probably the silver lining to that story is that through April through July, nearly all of our patients were patients from skilled nursing facilities. Certainly the vast majority of patients that were very sick were from skilled nursing facilities. So what we have here is a shift in the epidemiology whereby now we're dealing with more patients from the community and less from the nursing homes. And I think that's because of success of a lot of the infection control practices, not to mention a rapid upsurge in testing, which has been able to identify a lot of these outbreaks early and shut them down. To put things in context, that red, yellow, green system that people were talking about, that was stuff that we had developed with our work at LA County Department of Public Health and also in Orange County. So I don't know that we can say we own that, but we certainly were either the first adopter or one of the first groups to do that. I'm going to take a second to see if I can share my slides here. So give me 1 second. So, do you happen to have a copy of my slides up there, Ariel? Are you able to share that? Let's see if I can do this way.
You know, unfortunately, I do not, James.
Okay. I don't want to do this off the cuff, but I think I can here.
They sent him to Karen.
That's right. Give me a second. There we go. Okay, I'm going to leave the meeting and come right back again. Sorry, guys.
Thank you, everyone. Please bear with us while we pull up the PowerPoint presentation.
That should have me up and back, guys. One thing as I'm building this up here is that I do actually really appreciate the questions you guys have. So as you're going through, if you guys have questions, just go ahead and put them in the chat box and I can try and see if I can address them as we go. So here we go. You guys should be able to see my screen now. Is that in full screen? I'm getting a nod from, no, it's not, hang on. So view, slideshow. That should do it. So as I said, I'm still academic faculty at UCLA, and I do my work with Expert Stewardship. We do a lot of infection prevention services for Orange County and focus largely on skilled nursing facilities across Southern California. I'm going to give the group some data to look at, and I think this is important to put things a little bit in context. These are the US causes of death from 2017, which is the most recent time they published them. And as you guys are not surprised, you say heart disease, 648,000 deaths per year, the #1 killer in the US. And this has sort of been the top 5 of causes of death in the US for the last 20 to 30 years. The numbers will change slightly from year to year, but no major changes if I'm honest. If you look here, this is a map of the US showing the number of deaths from COVID-19. And this was, I pulled this slide deck together in September, so there was 200,000 deaths in September. This does not include data from the current surge, but you're looking at 200 deaths as of September. If I actually think about that number in terms of, what are other, pandemics that we're aware of, how severe is COVID, where do we land? I want you guys to think about in seasonal influenza, or regular flu and infection every year. That's usually 45 million infections, 810,000 hospitalizations, and 61,000 deaths. So COVID, up until September 2020, so this is just as far as we'd gotten by September, was 7 million infections. So not as many cases, probably 400,000 hospitalizations. So if you sort of make a rate there, we have far fewer infections, 7 times fewer infections, but almost half as many hospitalizations. And the deaths are way higher. So when you look at COVID versus regular influenza, COVID is clearly far more lethal and far more problematic. If we start to see more of this surge, which is when I made this slide, I was predicting this surge, saying, look, if we get transmission like we see from influenza, this is going to be a far bigger problem than we expect. So if I projected number of deaths from COVID for just 2020, it looks like COVID is going to be probably the number 3 cause of death in the United States for this year. That's far higher than we ever saw from influenza, far higher than we ever saw from healthcare associated infections. This is a big number. It really is meaningful and does mean that we have to jump on this. We have to do something to turn this around. Looking at people attending things like big Thanksgiving holidays or funerals and whatnot, I'm not surprised at all that through COVID fatigue, we're seeing more cases, but this is why we really want to be careful of it. Now, if you look worldwide, there's 31 million cases worldwide and almost 1 million deaths globally. So you can see that the US is contributing quite a bit more than other countries. Looking at other pandemics that you guys can think about. So HIV/AIDS has been around for 20 years, and that's usually about 700,000 infections per year. That's really what we've broken down to with HIV/AIDS. The 1918 flu pandemic, 20 to 50 million cases, 20 to 50 million deaths. Black Plague, 75 to 200 million deaths. And COVID-19, we're looking at about 1 million. That's probably what we're going to see, 1.25 million for the world. So relative to historical plagues, this isn't as bad as what we've seen in other eras. And part of that has to do with better infection prevention and better treatment. So just to be sure that everyone really understands this, where this is coming from, the origins and transmission of COVID-19. This horseshoe bat, Rhinolopus afensis, I'll tell you, this is my last super academic slide, and then we'll settle down and get more practical. But this is the horseshoe bat, and the horseshoe bat is known for just making billions and billions of coronaviruses. This is what made the original SARS-CoV-1 in 2003. This is what's made SARS-CoV-2, or what we know as COVID-19. So it all comes from this bat, and this bat will forever, as long as this bat is around, it will always make coronaviruses. Now, what's unique is that in China and in parts of Southeast Asia, it's actually legal to hunt this bat and other animals and then sell that meat for commercial use. That's very different than the US. In the US, you hunt for personal use. As a commercial venture, the contact between bats and commercial hunters is far higher. And this is really a big deal for transmission of this, not only for this epidemic, but for those down the road. So for those of you that are focused on animal rights, yeah, stop hunting in China. That'd be okay. Keep it in the US, but we can stop it there. Now, what's interesting about this is it's actually, the original virus is not just a pure bat coronavirus. There was probably a natural recombination event with this animal on the bottom right called a pangolin. I'm only including this picture to learn about the bats and sort of the social story of hunting in China, but also because I think that picture of a pangolin is absolutely awesome, and I now want a pet pangolin, which I think is, I'm sure, highly illegal, but it looks really cool as far as I'm concerned. This is an example of the Wuhan market, where you can see high density collection of people, which, as we know, is a great way to transmit COVID. This is where Wuhan sits in China. It really is in the center of the country, and that's why you saw resultant transmission down to Hong Kong, also Shanghai and South Korea. That's the flow of patients. Transmission of COVID-19 is really through 2 primary mechanisms. It's either droplet or contact transmission. There's a lot of conversation about, is this airborne and how big of a deal is this? To be honest, we've known that you can have droplet and what are called accelerated droplet transmission. So I show you a picture of somebody sneezing or coughing or singing. High sort of velocity airflow will increase the distance these things will fly. And the other one that people really need to be aware of is their hands. We know that your hands will touch all sorts of surfaces, and anytime you bring your hands above your shirt collar or go below your belt, you're at risk for transmitting this disease. Once you understand that, then understanding how to protect yourself personally and how to protect patients in skilled nursing facilities comes right clear. Ariel, is audio okay? You hearing me okay? Yeah, okay, good. So one of the things that I think people understand now, but this was established very early on. This is a New England Journal of Medicine publication published very early on that really described asymptomatic transmission. The idea that people without symptoms are able to transmit disease. The probability of transmission is lower before somebody has a symptom, but it's clearly there. This is why, frankly, we do the mass testing in skilled nursing facilities, is to identify people either in the early symptomatic phase or potentially in the pre-symptomatic phase to avoid an outbreak. And this really is important and established very early on that asymptomatic transmission occurred. I'm very disappointed to hear some local public health officials claim they were unaware of this. This is early establishment. Anyone worth their salt should have known this. So what are the essentials for protection? I've given you the basics. So the first thing here is social distancing. And this really is not only work, but also at home and how you create your social circles. In our family, we call it our quarantine. So who's on our team, who's on our quarantine, and you limit the total number of contacts you have. It's in my world where I'm going to finish this meeting and go see COVID patients and go into COVID rooms. The most dangerous thing I do is have a social interface with somebody out in my community. That's the most dangerous environment for me because I'm otherwise wearing a mask. Hand hygiene, how to do it properly and how to do it in a timely fashion. If there's any Orange County ombudsman on the call, you guys know we've already trained you on this and done all the hand washing experiments and how you do it. If you haven't been actually trained on how to wash your hands, you don't know how to do it. There's a couple of cool videos that you can watch that are sort of some hand gel painting stuff that goes through the steps, but it is worthwhile just reviewing what you should have learned as a kindergartner. The wearing of personal protective equipment. There's a lot of people that put a lot of stake on how you put the stuff on, but the fact of the matter is, as long as your mask is covering your face and you have a good seal, it's more about how you take it off and what you wear that is the most relevant. How you clean and disinfect, this is an important concept, and really it's just making sure that it's done and done properly. So I'll give you guys small tidbits as to how we actually talk about doing this, not only in the skilled nursing facility, but also in your own home life. So we'll focus on social distancing to start. And again, what I want people to remember is that asymptomatic transmission can occur. So just because somebody's done a temperature check or says they're not feeling well, that doesn't mean a darn thing. You can still get COVID from somebody who has no fever and who feels well. So the temperature checks, although they look good, don't really amount to much. So social distancing during breaks. This is important to think about when if you're going to be in an environment, and a social environment outside is way less risky than inside. More than 6 feet, way safer than less than 6 feet. And so really the idea here is you want to keep a lot of space between yourself and other people. And really 6 feet is kind of this magic number. Now, I call magic because it is driven by data, but it doesn't mean it's impossible for someone to transmit 7 or 8 feet away. If somebody's singing with a strong voice and they're singing at you, for sure that'll go more than 6 feet. And don't let your guard down just because you're on break. This is really relevant for skilled nursing facilities. When it's 10 o'clock at night, the night shift has been working, it's time for an evening meal, and 6 people pile into a small room to have a break, that is just a COVID transmission cubicle. Like, it's a terrible idea. So people have to think about how to do this, about carefully removing and storing a face mask, putting it on a paper towel, and then disinfecting the counter or table that you're working on. Those are pretty bog standard basics. This is a lot of stuff that we reinforce when we visit facilities or surveyors will visit facilities. And questions we talk about is, you know, how are you protecting your facility or your loved ones? Are you talking about this idea of social distancing? Are you talking to your friends and your family about who is actually on your quarantine? Are people recruiting other people to your team that you're unaware of? And really focusing on how to keep this as safe for you as possible. Hand hygiene. The biggest risk for getting COVID is from your hands. So when you're really thinking about this, when you wash your hands, there's a number of different surfaces you cover. I've got a good video here, so you guys are going to see it. The first part is you rub your hands together. Ariel, I'll have you copy along with me if you want. You rub your hands together. Then you interlace your fingers back and forth, right? And you cover the back. You get the other back of your hands. You can see my hands are still interlaced. You get the wrists, the thumb, fingertip, fingertip. And that's exactly how you should do it for alcohol-based hand gel. It really is a process. You've got to get all those surfaces. Alcohol-based hand gel works by drying your hands out. So anytime you go into the supermarket, you want to go through hands together, interlace, back, wrist, thumb, fingernail. Okay, everyone's got it. So we'll go through it again. Squirt of the hand, hands together, back between the fingers, wrist, thumb, and fingertip. And you wait until your hands are dry. If you're not applying wet lotion to the back of your hands or to your fingertips, you're not doing anything. You're just rubbing your hands together. You really got to make sure you totally coat your hands. So monitoring of hand hygiene, I'll be honest, Tony's comment made me laugh a little bit. We've had troubles with hand hygiene in all sorts of facilities. And the fact of the matter is, unless somebody's actually watching and reinforcing something like that on a routine basis, and until you get peer pressure, it really doesn't work. But the rules here are always wash your hands before your hands go above your shirt collar or below your belt. That really is what I want everyone to think about. The other one to do is before you get into your car or out of your car, keep yourself in a relatively safe space. In a social setting, we talk about red being like the supermarket or a grocery store or a barbershop. That's a red environment. Yellow is probably your car, where you still want to stay relatively careful. And then green is your house, where you want to make sure you're really, cleaned and bathed as you make those transitions. So personal protective equipment. I like to show this slide because this is what it looked like if you were managing COVID patients in Wuhan, China. For those of you that remember, this looks a lot like the movie E.T., like the guys that had the big bubble when they went to go visit E.T., they had to walk to. It's very, very similar. And the fact of the matter is that's not what we do in the United States. In the US, we want some version of eye protection. I've been wearing these glasses ever since the start of the epidemic. In theory, you want a bit more of a face shield. I've been wearing a surgical mask. So this is my surgical mask here. I'm not going to put it on because I didn't wash my hands, but that's the surgical mask I've been using. Gowns and gloves. For aerosol generating procedures, there's a lot of interest in using N95s. For me personally, they're not practical. I just can't wear it all day long. And there's different benefits here. But what I want you guys to understand is that there is a big difference. You're looking at guys in full bunny suits with face masks and whatnot. And the reality is that almost a third of healthcare workers in Wuhan, China contracted COVID, whereas in US hospitals, it's less than 3%. It's actually lower than the general population for a lot of places if you're looking at healthcare workers. And that's because it's not how much you wear, it's how you wear it properly. And most people are more likely to contaminate themselves putting PPE on and off, well, it's actually off, incorrectly. So if you have to get into or out of a bunny suit, you've got to be like a gymnast or like a ninja artist to get into these things and not contaminate yourself. It's a skill set. And if you haven't trained on it, it's not one you want to learn now. So just use what works. And we know that proper use of PPE is highly successful. We've shut down dozens of outbreaks in all sorts of kinds of facilities. I mean, I forget the count now, but we're probably over 100 outbreaks at this point that we've shut down by really focusing on this strict use of PPE. And this is an example of how you can mess up wearing PPE. And what we've done is that, in this case, this is an experiment we do for training people, is we'll put a glow germ, it's called glow germ, you put that on your hands, and then you put your PPE on and off, and you can see that this person on the right has actually contaminated their face by touching their face or touching their eyes without washing their hands. And this is really one of the biggest problems you're going to see and the biggest risk factor for transmission. The last one is cleaning and disinfecting. This is really, really detailed, and it's honestly really painful. I've taken this from the University of California, Irvine. The directions for how to clean properly go all the way down to how to fold a cleaning cloth. They're like, there's a right way and a wrong way to do this. And what I want you guys to see here is that I would just, if I'm at home, I would just grab a rag, ball it up, and wipe down whatever I want. But if you're really cleaning properly, there's like an 8-sided surface you have to use to clean. And this is really detailed expertise. Infection preventionists are a rare breed. They not only know all this information, they retain it, they can teach it, and they're experts. It's a really rare resource to get very, very good infection preventionists, and trying to bring those resources to skilled nursing facilities is what the Department of Public Health and others have done, but that's a big need, really making this a professional experiment. Here are the different high-touch surfaces that we talk about, things that need to be cleaned, doorknobs and night light switches, and there's a way to actually survey to see if these things have been cleaned properly. This is an example for the order in which an area should be cleaned as you go from what should be cleanest to dirtiest. There's a process that goes here. Again, another similar training process that we go through for different groups and environments. To sort of belabor the point, honestly, because I thought it was funny, there's actually a mopping pattern. You can't just mop a room. You have to like mop from clean to dirty. So there is a way that you're supposed to do all these things to make sure you reduce the risk of transmission. The most important thing, though, is you want to make sure that people are actually doing it. This is a UV marking system. We've done this in research and practical applications of using a UV gel, and we can tell, did they actually clean it? For example, this image on the left, where you can see that this UV light is very bright, you can see no one cleaned that. No one's touched that surface at all. This surface here, you can see that somebody's partially cleaned it. And this one here, someone's finally actually fully cleaned that surface. So it's a nice feedback system that we've used in many facilities to encourage environmental cleaning. So essentials for protection: social distancing, hand hygiene, PPE, cleaning and disinfecting. The last one that really is worth talking about is some of the decoding of public health messaging. And this is something that we were hearing about from our former presenter, was that public health is not usually filled with people that actually understand skilled nursing facilities. I spent the better part of my career helping skilled nursing facilities with infection prevention. And a lot of times I'm faced with translating what public health is trying to say versus what's feasible. And you also have to understand there's multiple levels here. There's CDC recommendations, state and local public health unit, and there's differences between licensing, which is kind of the surveyors and those that give deficiencies, and the disease control units. One of the things that's been interesting is that there haven't been as many infection control deficiencies this year because we've moved to sort of a collaborative model in a lot of settings, and that's more of the disease control units having more of a role. But each level of these groups has their own playbooks. Their playbooks don't always disagree. There's some guidance here you can look up if you're really interested in skilled nursing facilities. But it is really worthwhile talking about a mass testing strategy. This has worked extremely well in nursing homes and is probably related to how we can get out of this, if not a vaccine. I'm not talking about vaccines today, but happy to take those questions. So we've applied monthly testing as what CMS had recommended. September 12th, CDPH, brilliant recommendation to encourage weekly or bi-weekly testing. And really, this is a really good way to do it. And it's really based off of a very, very nice scientific analysis that was initially published in MedRx before it was formally published. But people have looked very carefully at the transmission rate of COVID. And within the skilled nursing facility, about every week is about right to stop these outbreaks, given what we know of the R0, if people are at least trying to wear masks. So when you understand the science of why people are doing things, it makes these different recommendations easier to understand. So I don't want to spend all the time in the world going over this. I'm not sure if there's any questions because I've somehow lost my chat box, but I really appreciate the chance to chat with you guys. I appreciate you guys letting me be a little bit herky-jerky. We are clearly in the middle of a COVID wave now, and I'm definitely getting better at treating this disease. Our treatment paradigm is totally different and lots of things to talk about, but happy to take any questions, guys.
James, thank you so much. We do have some questions coming in. If asymptomatic transmission can occur, What is the argument for checking temperatures before entering a facility? And should we avoid it altogether because of this type of transmission?
No, the idea behind checking temperatures before somebody comes in is actually multi-layered. Number one, it shouldn't just be checking for temperatures. It should be checking for temperatures and asking, how are you doing? How are you feeling? Do you have any sickness? Hey, by the way, if you get sick while you're here, you should go home. That's really important because when somebody gets symptomatic, their risk of transmitting goes through the roof. They're way more infectious as soon as they have a fever. Fever is the big indicator. Once somebody has a fever, they start to transmit to everybody. Asymptomatic transmission can still occur, but it's not as easily done. The reason why I raise it is don't develop a false sense of confidence with temperature checking. That isn't it. You can't say, oh, well, I checked my temperature, I can take my mask off now. Like, no. The temperature checkings are good. It's one step in a multi-tiered approach to prevent transmission. So keep doing it, reinforce the symptom check, because to be honest, that's probably more valuable than the temperature check itself. But you do have to reinforce the idea of we're protecting this for a couple of reasons. Great question, whoever asked that.
Oh, you've got a bunch of them coming. So here's
Good,
a couple
fire away.
more.
Yeah.
What is your opinion of hospitals allowing nurses to continue working who test positive but are asymptomatic?
So we will not let positive work in our hospital. If you're COVID positive, you're out for at least 14 days. And that's pretty standard. In some circumstances where you have severe staffing challenges, somebody who is wearing a mask is way less likely to transmit. In the nursing home facility, some COVID positive nurses were working in the red unit with other confirmed positive patients, but that was only where the entire staff was all COVID positive. You have to worry about transmission not only to patients, but also to other staff members. So it's possible, but golly gee, I wouldn't want to do it unless I absolutely had to. So I'm not a personal fan. In fact, in Orange County for our nursing homes, I don't think we've had to do it at all. I don't think that's ever been required in the nursing homes in Orange County.
Okay, great. The next question is, due to the nature of COVID-19 and the risk for older adults, is there data with regards to vaccine testing with older adults and the reactions, or should older adults be concerned with unknown long-term effects of vaccine?
So the vaccine approach here is fascinating. There's a lot of early data that's come out about efficacy of these vaccines. And to be honest, I think one of the important things to realize is that no step has been skipped in the development of these vaccines. All of the routine traditional vaccine safety checks have all been done. There's nothing that's been skipped. My one limitation is that I haven't seen all of the data yet. So I'm enthusiastic. If the efficacy is anywhere near what they're talking about, this is a home run. I mean, we were hoping for something that was like 50 or 60% effective. If you're talking 94% effective, this is a game changer. So this is a really, really exciting time to see where this goes. I'm waiting to see the full data sets before I really come out with a solid recommendation. I know my partner, Phil Robinson, who's at Hoag, he is literally the first person in line to get the COVID vaccine. So, you know, I'm sure I'll be one of those early adopters because of the risk of exposure I have. And the point is well taken. Older individuals or those at higher risk should certainly be thinking about the idea of taking this vaccine earlier just to prevent any downstream effects. So that's really good thinking. I just don't have the above 65 adverse event rate to comment on. But given the fact that the initial outrush of vaccines is going to be massive, I'm sure we're going to get a ton of data very quickly.
Okay, great. How about regarding the death rate of heart disease and COVID? Did people die of heart disease with COVID, or was COVID the primary cause of death for someone who had heart disease?
Yeah, so there's two sort of scenarios that occur with COVID deaths. Either they're super, super fast, where somebody's doing just fine, they get critically ill, and they never get to the hospital. Like those people, they're just so sick so fast, the 30-minute ride from wherever they are to us, they expire in that time interval. That is really rare. And when those rare events have occurred, those are probably arrhythmias, cardiac arrhythmias. Someone had some myocarditis and had an arrhythmia event. But that is absolutely the exception to the rule. I can't think of the last time we had somebody like that. It's extremely rare. What we usually get is a very slow, gradual development of symptoms that progresses over time. And what happens is we have lots of opportunities to intervene before somebody gets critically ill. And it's usually on the order of, 4 days to 15 days, somewhere in that window of time you have to intervene. If we can intervene early with treatment, we nip it in the bud. We have none of those really complex, convoluted cases. Once something gets way out late and they're hard to turn around, those patients, if they have underlying heart disease, the COVID gets them critically ill, and then their heart just isn't strong enough to maintain that critical illness period. And that's how they ultimately expire. It's very rare. In fact, like I said, we don't have many at all in my hospital. I think we've treated over 1,000 of these. I think Hoag is similar numbers, also 1,100 or 1,200. We both have very large active research programs. It is certainly a bad prognostic indicator if the heart is affected, but that doesn't appear to be the primary reason that people die.
Okay. Another question we have received is, after administration of the 2 doses of the mRNA vaccine, how long does it take to become effective in the recipient?
So if it's like any other vaccine, you probably have some protection after the first vaccine and more protection after the second. If you really want to see the immunology, it's probably a natural logarithmic curve where it slowly ramps up over time with more of the benefit later on. What you're really trying to do is get your B cells and memory T cells to fire up. I can't imagine you have much benefit in less than 3 weeks. You probably get some, but when you're out 4, 6, 8 weeks, that's really where you're at your peak of protection, if it works like anything else. Now, remember, the question here is specifically about mRNA vaccines. So a lot of the time frame for what I just talked about is based on like traditional antigen neoadjuvant. It may be actually much faster with the mRNA vaccine. It's in certain ways a more natural way of developing immunity.
All right. Another question we received is, are there any concerns about drug interactions with the vaccine and medications someone has to take daily, for example, HIV medication or blood pressure medication?
I'm going to punt that question. I don't actually know the answer to that. I don't believe so, but I don't want to misguide somebody on one comment here.
Okay, I'm going to jump to the next question then. This one's a little bit longer. I worked at a mental health rehab center during the first 6 months of the pandemic. We had a terrible outbreak of COVID, which I believe was directly related to poor management and oversight. We had PPE shortages and staffing shortages. Testing was not mandated in certain situations. However, our facility did not meet the criteria for long-term care. This data was not being made public. Has time changed? Why would data related to COVID on MNRCs not be made public?
So first, thank you. To whoever put that question in, thank you. You're one of the people that were in the trenches. And a lot of us were in the trenches. When you talk about a healthcare hero, that's you. Whoever asked that question, thank you for that work. That was a trying time for everybody. It was a scary time for everybody. And those of us that literally put our boots on and showed up to work, it felt like we were going into battle. So, thank you for that. That's something that I did and others did, and it was scary. I'm also very proud to say that in Orange County, we would be all over that. If that had come up ever since my group, Expert Stewardship, has been involved in Orange County for, probably not as early as that event, but later on, we would be in that facility, helping you with PPE, all over training your staff, making sure that people knew what to do and how to do it. Because you're exactly right. Any patient in any of these environments are really vulnerable. You bring up something there that's a little bit tricky, is in the skilled nursing facilities, they're mandating infection preventionists. There's lots of room for improvement. In smaller RCFEs and smaller units, or even some of these psych units, there's not as much of that structure or requirements, and it's something that has to evolve. And Tony in his presentation previously was fantastic. He really talked about what the advantages and disadvantages of that were, how to engage the ombudsman. I don't think you have an ombudsman equivalent in that environment, but something along those lines, like a community oversight person to help guide and help advise, would be very helpful. But really, to answer your question, we take those kinds of outbreaks and those kind of scenarios very, very seriously. And PPE now is completely different than it was. We have sufficient supplies. We have all sorts of effective ways to extend them, but we don't need that as much anymore. We've evolved, if you will. So again, thank you. Great question.
Okay, we've got a couple more questions for you before we wrap up. Do skilled nursing facilities, elderly patients who develop COVID stay in the facility for treatment, or do they send them to the hospital? If so, is there a standard for putting COVID seniors on hospice as opposed to aggressive treatment?
So I'm gonna wear a couple different hats when I answer this question. I'm actually board certified in hospice and palliative medicine. I did a lot of hospice early in my career. To be honest, it was my like, I'm an academic and I can't make enough money, so I need another job kind of thing. But I loved it. I care a lot about hospice. Similarly, like I care a lot about skilled nursing facility patients and how you engage with them. We absolutely take a very aggressive approach to treating anyone coming from a skilled nursing facility setting. I would not well, unless somebody is already going to be on hospice and they then get COVID and they're already on hospice, there is no rule here. These people come in, they get treated. So the traditional method here has been if someone who's in a skilled nursing facility, they start to get sick, they come into the hospital and they follow the same exact treatment protocol as anyone else. If I'm honest, I'm more aggressive with nursing home patients because they tend to be more frail. They tend to be a little bit older. So they're residents in the facilities, but once they're mine, they're my patients. So pardon the word slip, but those patients I'm very aggressive with. We do a lot of very aggressive treatment, curtailed to the geriatric population. So we're a little bit more ginger with blood thinners when we need to. One of our active areas of research, one of the things we're actually doing right now with expert stewardship, is trying to bring a lot of the hospital-based treatments to the nursing homes and trying to figure out how to do that to make sure that it's efficacious, because we know that early treatment is better. One of the structural problems with doing that, I'm already thinking on the back end of marketing it, is that reimbursement for that treatment gets very tricky and needs to be fixed. But I think there's great opportunities here to work on that and go from there. Next
All
question.
right. We have a couple more in here. They just kind of keep coming in and hopefully they're a little short and sweet. How do we connect with resources to help with staff training and advising COVID best practices?
So sometimes the local Department of Public Health can be really helpful. Tony, I appreciate that the messages get mixed, and trust me, I'm fully aware of that, but sometimes your local Department of Public Health can be very helpful. I know that we have done a tremendous amount of training in Orange County and other areas as to how to do it. We've got a playbook, if you will, of how to respond to a COVID outbreak, how you establish your red unit, yellow unit, green unit. But it really comes down to a lot of really true, excellent infection prevention training. We've worked with some top folks in the field. So Dolly Green and Nancy Paris do a lot of infection prevention training in skilled nursing facilities. They work with us heavily. Really, it's keying into local infection prevention knowledge. And you guys are welcome to reach out if you have questions.
All right. Can the type of symptoms you experience if you contact COVID-19 be indicative of how long or how much one would transmit the virus?
It's a great question. So there are a few things here that will naturally encourage transmission of virus. So one is fever. Fever is suggestion that you've got a tremendous amount of virus. You got lots and lots of billions of virions in your body replicating away. So fever, for sure, you're way more infectious. And then anything that's going to make transmission more efficient. So if you're coughing, if you've got ripping coughs, you're shooting those viruses further out. Diarrhea, we live in the first world, so you're usually using a toilet, not that big of a deal. But anything where you're coughing or sneezing, those two things would encourage projectile of virus particles.
Okay. And I have a last question here. I tested that I had COVID antibodies in September. When I retested for antibodies in November, my COVID antibodies were gone. Do I still have any COVID protection even though my antibodies are gone?
Oh, I'm sorry to give you some tricky news here. So if you just got an antibody test and you never had COVID, then I really don't trust those test results. And the reason why is that there are literally thousands of coronaviruses and a lot of them will cross-react. So a lot of the antibody tests on their own are useless. It doesn't actually tell me that you actually had COVID or not. So if you've never been confirmed of having COVID with a PCR test, which is up the nose, we call them the brain biopsy ones, then it's really not clear if you actually had COVID at all, and I wouldn't trust that antibody response. Now, tweaking it slightly, if you were diagnosed with COVID, we think you have partial immunity from COVID for the better part of a year. Now, I only say a year because we've only had the disease around for a year. But if you get admitted to the hospital, essentially nobody comes back in again with another case of COVID. It just doesn't happen. Even the cases you see in the literature of people being reinfected, it's what happens is the test will become positive and negative over time. And it has to do with expression of dead virus particles, has nothing to do with presence of disease. So it's a little bit tricky, but if you actually had COVID, you probably have at least partial immunity for the better part of a year. And if you just have an antibody, I don't know what to tell you if you didn't have a COVID original diagnosis, except for you probably should still get the COVID vaccine if it comes out.
Okay, just one more that came up that was tying on to what we were just discussing.
Yeah, sure.
If someone already had COVID, do they immediately have antibodies? And if they do have the antibodies, should they not get the vaccine? Would you need to be tested for antibodies before receiving the vaccine?
Yeah, so we think that well, there's a couple different ways to answer that question. So from what I've understood so far, that the vaccine is safe to give in people who've already had the virus. So if you've had the virus and you want the vaccine, you're probably safe. If you've had the virus and don't want the vaccine, I don't know what to tell you. Like, there's no science there as to how long your immunity will really last. Are you going to have a year? You're going to have 5 years, you're going to have 10 years, you're going to have 1 year. Is it better to have COVID and the vaccine, or just COVID? Nobody knows, because we haven't that many people vaccinated yet. So there's many, many layers of why that's a complicated answer. I would argue that if you've had COVID, then you're a better person to be, well, you're a better person just in general, but if you've had COVID, you're a better choice as somebody to take care of other COVID patients because of that partial immunity question. I would still wear PPE because you don't really want a big, massive reinoculation of the virus. And there may be other viruses going around, like influenza. And if you've had COVID, you don't want a second viral infection. I'm really worried that my COVID recovered patients are going to get influenza and have a terrible course of it, because we know there's some chronic changes to the lung that they're still healing from, and they've already had a lot taken out of them from the original COVID approach. So COVID infection. So I'm actually a little bit feisty about my patients and continuing to wear masks even after they've had COVID, just to make sure they don't pick up echovirus or enterovirus or one of the other viruses, just because they're more frail this year than they were last year.
Okay, well, thank you so much, James, for your informative presentation and answering all of our questions.
I really enjoyed it. Thank you guys very much.
That's going to be a wrap to our event today. Some final remarks for everyone. There will be a post-forum email with resources and